have the speaker please come to the podium. I'll just echo what Michael said regarding the sham control trials, because these endoscopic procedures are just suited perfectly for a sham control, and it's really a pity that they were not done so far or not being done. It's a question perhaps to Dr. Adami. Do we have any predictors? Can we tease out from the studies that were done so far? Is there a difference between the surgical gastroparesis and medical when it comes to intervention of the pylorus, these two entities being so completely different in terms of pathophysiology?
So we'd like to think so, because the post-surgical gastroparesis is really the ideal patient population for this. However, we've also seen that sometimes there's a very tight angulation in the pylorus, especially after, say, esophagectomy, and that can be increased once you do the pyloromyotomy. The numbers have been really small so far, but that's something that's certainly going to be looked at in a little bit more detail.
Let me ask you a question to follow that. Obviously, the GPOM and Botox, everything, you're trying to reduce the outflow obstruction. And we have a lot of data from the surgical literature with regarding to performing a either laparoscopic or open gastrojejunectomy, essentially eliminate the outflow obstruction completely with a very big anastomosis. I know you didn't really present those data because those data were pretty much disappointing. So I just want to hear your thoughts regarding to really trying to work on reducing the outflow and the history of the gastrojejunectomy data.
Yeah, I mean, it's really complex because there's so many different mechanisms. So, are we trying to eliminate pylorospasm? Is there, a functional obstruction that we're trying to eliminate? And that's why, we've been doing a lot of the stents, because it really mimics the way that the pyloromyotomy might work in the future.
Let me ask one question first before we move on to the question from the audience with regard to either the endoscopic or the bariatric operation. First, Lena, with regarding to reflux disease after sleeve gastrectomy, what can you say? How do we evaluate those kind of patients? Is it endoscopy? Is it epi-GI? What do you do for these patients to evaluate the reflux disease?
I would evaluate the patient the same way I evaluate any reflux patient. So they need a minimum of 4 studies. They need an endoscopy, they need an upper GI esophagram, they need to have some sort of a pH study, whether it's pH with impedance, so you can also assess the non-acid reflux, or a 48-hour wireless pH study, and a manometry, and then plus minus gastric emptying if you think that might be a factor for that patient.
Okay. Notoriously, what we notice is that the endoscopy comes to us, particularly from the outside institution, is that it's essentially normal. But the definition of normal endoscopy post-sleeve is a little controversial. And the reason for that is that this issue of the angulation and narrowing of the incisor, although you can able to pass the scope through the incisor, doesn't mean that there is no outlet obstruction. I think that's where really, I think this is where the flip is going to really help. So I think if we have the flip data, we are able to identify the site of the partial narrowing, even though the scope can actually angulate around there. I think there's a lot of outflow obstruction associated with that.
Sure, I think understanding the morphology of your sleeve is very important, and combined endoscopy and the esophagram upper GI are going to help you figure that out, because even though endoscopically, for example, your scope might go right through the sleeve, but you do that esophagram, and functionally when you're watching that stomach work, you see a big fold, and it kind of looks like a U or a horseshoe rather than, a nice kind of elbow of a sleeve. So that's really important. I think, we do a lot of our own endoscopy, but we also have a lot of gastroenterologists that we work with. And so we've really put together a paradigm of important factors that if you're doing an endoscopy in a person post-sleeve or post-bypass, there are certain parameters we want to know and that they should be in the report. And some of that has to do with whether there's an angulation at the incisura. Did you have to make a sharp turn? It's important to elucidate that. Whether there's the presence of a hiatal hernia. Do you see any narrowed areas in your sleeve? And then also, I usually do a retroflexion in the antrum to look back up my sleeve, and if the scope, the stomach is tight to the scope, kind of like an LES would be, you know, that person, that's another indication of that angulation. So that's helpful to take that picture and to also report that, because these are so important to the mechanism of the reflux and may sway you from, for example, addressing the hiatal hernia and the LES versus converting that person to a bypass.
Seems like we have a lot of questions, so maybe just ask your questions succinctly. We'll start from over there.
Referring patients for gastric stimulator after GPOM, or just want to get your thoughts on how do you combine the surgical approach as well as the pyloric interventions, and when would you do that for your gastroparesis patients?
Yeah, so some patients that may have had, you know, maybe only a modest or no response, that's certainly a consideration. We don't perform the stimulators at our institution, but we have referred patients out.
Do you ever do stimulators first, and then, or if the patient meets certain criteria, is it always pyloric interventions before referring out for stimulator?
I mean, we've had patients that have come to us with stimulators done previously, but no, we're not. Basically, patients are getting the pyloric interventions first.
Next question, middle aisle.
So, Michael, a question for Ravi Middle. You know, only one thing you said in your presentation is the news, and I want to, you know, expand on your news in the sense of the symptoms and the relationship with delayed gastric emptying, because I think that's a very important concept. But, you know, so two things. One is, yes, there is some relationship, but is it the cause and effect relationship? And do we really need to treat delayed gastric emptying to relieve the symptoms? So I think ultimately the proof of the pudding is the objective measures of delayed gastric emptying and the improvement in the symptoms. Do we have anything along those lines?
Yeah, I had to go through this rapidly, Ravi, but that meta-regression plot actually addresses exactly that question. And so if you have an improvement in gastric emptying T-half of 20 minutes, you have at least 1 point change on the gastroparesis cardinal symptom index if that was the measure used. So basically, the second paper that we've just published in Gastroenterology shows that if you give a pro-motility agent and you improve gastric emptying, you will have an improvement in symptoms.
Why don't we go with that microphone over here?
Thanks, Sumit Middle, excellent session. I have a few comments and a question. One for Dr. Aziz is, you know, you said the patient selection, no narcotics, and no psychiatric history or medications. I have not seen a patient like that with gastroparesis.
No.
That's the first thing. So,
No, I think there's a difference. So the patient who is on daily narcotics and completely narcotic dependent, we send those patients to our pain clinic and try to get them off of those daily narcotics because they're not going to do well. As far as the psychiatric conditions, we want them just to be managed better.
okay. So the real question is actually the paper that you quoted out of Cleveland Clinic about GPOPs. They do not depend on a gastric emptying study to make the diagnosis. And any comments on that, because it's very important to know that what are we objectively measuring pre and post intervention. Majority of the patients actually do not have delayed gastric emptying documented by preoperative gastric emptying study. In fact, had normal 4-hour gastric emptying study.
Yeah, so then the question is, do they have true gastroparesis or do they have a gastroparesis-like syndrome?
Yeah, because they have excellent outcomes for gastric emptying study.
Right. I mean, the other thing is that their definition of success was actually narrower, right? Was broader. That was a 0.75 increase. You know, most studies have looked at a 1 point improvement. So, yes, they do have better outcomes because the outcomes they're looking at are broader.
We'll take one more question, and then we're going to actually have to end this session because we have our keynote speaker next. So why don't we just take your question?
So this is in regards to gastroparesis, and when one of these meetings I heard that the sleeve gastrectomy improves the gastric emptying. So I extrapolated that to 4 of my patients that had failed medical therapy, and I did all 4 of them sleeve gastrectomy, and out of that, 2 I've converted to subtotal gastrectomy to 2 years and 3 years, and 2 of them are still out there with the complete resolution of gastroparesis. Anybody else is using that, or what are your thoughts on it?
It's definitely one of the treatment choices. It's a little bit extreme because they're already at a very low weight, but I think for a lot of patients who have no other viable option, then this has been discussed. But again, very early data on that.
Yeah, I would agree with the sleeve. I'm honestly hesitant to do a sleeve in these patients, although there is that data, but I think that it's worth studying. My preference in those patients often is to do a gastric bypass with, oftentimes I'll leave the remnant there, and most of them do okay, and then if I need to remove the remnant later, I will.
Great. With that, I want to thank you all, the speaker, and then let me ask Dr. Ken Wang to come up to introduce our keynote speakers.